Hi, I'm Summer May Finlay and I'm here with Scott Monaghan, the Chair of the Aboriginal Health and Medical Research Council, and we are here at the Aboriginal and Torres Strait Islander Health Summit, and the AH&MRC is one of the co-hosts. So Scott, could you introduce yourself for us?
Scott Monaghan. I'm a chairperson of the Aboriginal Health and Medical Research Council. I'm also a Chief Executive Officer of Bulgarr Ngaru, which is in northern New South Wales, located in Grafton, with service centres in Casino and Tweed Heads. So we've got a footprint same size as northern New South Wales local health district.
Yeah, fantastic. So the summit theme is Aboriginal health. It's time for a reset. Can you tell us a little bit about why you chose that theme?
Look, I think it's appropriate. It's time to look at and review what we're doing. I think it's time to look at a patient journey, because I think too often now the patient journey is fragmented. If you go into the hospital these days, so you may, as a medical service, get a discharge summary back, or may not. You may get the information back. So I think it's time to reset, look at what we do. Go back and revisit partnerships. Go back and see what's worked in the past, and if that's validated, push forward with that. But also to look at what hasn't worked and why that's not working, and just have a revisit as to whether issues are structural or whether they're personality based. Because sometimes in between area health services, the primary health networks that are now funded, and AMSs, there can be a them and us approach, and that's also from the AMS perspective, but also from the LHD, where their thinking is around hospital beds and not how it affects the Aboriginal medical services. Because there's a great opportunity for AMSs to minimise days in hospital. There's a great opportunity for AMSs to assist the local health districts and the primary health network in delivering health services to some of the most vulnerable people in our population.
Absolutely. And for those that don't know, New South Wales has the largest Aboriginal population and also has the largest number of Aboriginal medical services here, and also has the first medical service. So New South Wales has been leading this space for quite a long time, hasn't it?
Yeah, look, we have been leading, with Redfern and having the largest numbers. But I think, in New South Wales, I'd like to say that we're innovative in how we do health. I'd like to think that we, don't shy away from the tough decisions, whether it be with the Commonwealth, with state health, or with the local health district. We look to try and provide the optimum healthcare we can for Aboriginal people. And we've got to remember that sometimes in some of our towns, there's not an AMS present. So we need to work actively with the primary health networks and the local health districts, and challenge them on how they're going to provide services to Aboriginal people that sometimes have to travel to an AMS. It could be up to 200 kilometres away.
Yeah. So with today's agenda as well, I've noticed that there is policymakers on there, researchers, as well as representatives from the ACHO sector, and also that most of the panellists are actually Aboriginal and Torres Strait Islander. Can you tell me about some of the motivations behind that?
Look, I think it's always good to have a mixture. Research, Aboriginal people are some of the most researched people in the world. What does that mean to us? I think, as a health perspective, sometimes not much. Policy makers, sometimes the policy makers make decisions removed from, what is effective, primary health care. So I think it's a good opportunity to get everyone in the room, have that discussion, and emote some ideas about how we can do something different for a change. And sometimes that phrase is coined fairly often, but I think we've got the right cohort of people in the room to make those changes, and start the fires, I think, to provide better healthcare.
Yeah, fantastic. And I also noticed that there is a partnership between AH&MRC and the Ministry of Health on this summit, and there's also a partnership outside of this summit. Can you talk to me about why that partnership's so important?
Look, I think it's key to have that direct dialogue, because a lot of our services are funded from the ministry. So it's key to have that dialogue to try and steer the ship, to provide the best resources we can to our services on the ground. But as I mentioned a minute ago, also to provide services to people that don't access an AMS. So and there's all sorts of figures thrown around about how many people access an AMS as opposed to don't. But I think it's everyone's individual choice as to whether if they choose to access an AMS, that's great. But if they choose to access a mainstream GP, the services should be the same or similar to what we get in an AMS.
Absolutely. As someone who works in the health sector, I tend not to access an AMS because I often have to work with Aboriginal medical services, and I have to say there is variation across mainstream GPs as to whether or not they're culturally appropriate, and that was something that was raised this morning as well, was the cultural appropriateness of mainstream services.
So for me, I'm up next on the panel, so my discussion will be about what's working in northern New South Wales and why is that unique as opposed to being the norm across the footprint in New South Wales or Australia, in fact. Because if you talk to I talk to many different chief executives from Area Health Service, and they ask me, how do I work with an AMS? And from the AMS perspective, they say these Area Health Service won't even return our calls. So there's a bridge there somewhere that needs to be built, or there's just some open dialogue that needs to start so that we can get that seamless patient journey through the system, so that if someone is in hospital, your doctor at the AMS or your doctor at the private clinic knows exactly where you're at and at what stage you're at, rather than getting a discharge summary 3 weeks later.
Yeah.
If they get it.
Yeah, it's a common thing. I've done some work, some research in the space around heart disease, and discharge summaries was one of the key things that often didn't get received by the AMS. And that relationship between the primary and tertiary healthcare sector is really important for continuity of care. So.
That's exactly right.
Yeah. Did you want to add anything about today's summit or about what you're going to present today?
No, my talk will be really about partnerships, about why some partnerships work and why they don't, but just lighting the fire, I suppose, on having that discussion when people leave here and go back home, and really consider what they're doing. If it's working, that's great. How do they build on that? But if it's not working, what do they need to do to get it working? Because really at the end of the day, no one owns the patient. The patient goes through the system, should be seamlessly. As we know, that's a difficult journey at the moment because it's we operate in silos. And my goal, is to try and, if you do go into the AMS land or into private practice, go into hospital, it should be a seamless journey no matter what you do. No. And you get the best healthcare that you possibly can.
And that's, I guess, that's the intended outcome, is by resetting and refreshing those relationships, hopefully we do actually have better outcome for our patients.
That's exactly right.